Thank you very much. Thank you very much. Good morning to everybody. I would like to start thanking the academia and specifically Professor Genassani for inviting me here. The topic I should discuss with you is about the endometrium. First of all, I'm going to show you some data and make clear from the very beginning that I have no conflict of interest in what I'm going to show you today. Now, from our own data generated in our own clinics, we have learned that in the best scenario, the chances of an euploid embryo to implant is about 66%. We cannot do better than that. So that means that approximately 34% of our patients don't get pregnant and we don't know why. And one of the places we want to look is obviously the endometrium, because we know that implantation is all about a dialogue, a molecular dialogue between the embryo and implantation. And this is why we have focused many years in our foundation at EV working on that under the supervision of Carlos Simon for many years. Now, when we want to look at the endometrium, we want to do it on a 360 degrees perspective. We want to analyze visually what's going and morphologically what can we learn from analyzing the endometrium from this particular point of view. And also we have dedicated a lot of time, a lot of our research and time to analyze the endometrium at a transcriptomic and secretomic level. And in the last years, I will show you some data that we have generated in our foundation looking at the microbiome of the endometrium, which maybe is a next chapter, but today I will show you some data that have been already published. Now, if we look again to all these things as a puzzle, looking particularly at the morphology, I think that most of you know this paper. If you don't know it, just you have there the reference, because this is a multi-center trial in which our chairman participated and many people from other places of the world. The researchers included in two groups patients with repeated implantation failure, more than 350 patients per group, and the question was whether hysteroscopy before IVF in women with repeated implantation failure improves outcomes. And the answer, as you see, looking at pregnancy rates per women included in the study, per embryo transfer, or per considering only women with top quality embryos, is that in hysteroscopy does not add any new information that is not provided already by ultrasound. This is basically the story, and also has no scratching effect at all. So it will not increase your pregnancy rates. Now, however, I want to spend most of my time speaking about what we have been doing mostly, which is to look at the uterus at the molecular level, because since 1950 we looked at the possible function of the endometrium doing histology. The Noyes criteria described in the first issue of fertility and sterility in 1950 has been the Bible of our behavior over the years, and today we are in 2017. So José Horcajadas, Carlos Simón and others did a lot of work, again, starting many years ago, and trying to describe the endometrial signature, which is basically applying the noise criteria but to a molecular level. So they described 238 genes which were important to analyze, or important to discover or to pinpoint when the endometrium was receptive, based on, again, on the dogma that the embryo approaches and attaches the endometrium approximately 7 days after the LH surge, or 5 days after progesterone increased. And with that, we put into the market the endometrial receptivity assay that now is commercially available. As it is available, this test that was also put in the market by Joson Horcajadas, which is called the endometrial receptivity map. So these two tests, and maybe others that are commercially available, what they do is to get the molecular signature of the endometrium in order to understand whether the endometrium might be in a pre-receptive status, whether the endometrium, is in a receptive status, or whether the endometrium is in a receptive status. Exactly the same that you did in the past with the out-of-phase endometrium. Remember that the pathology said this endometrium is out of phase or is in phase. So basically it's the same, but at a molecular level. And what we have learned over the years, looking at our patients at IVI, was that many patients have the window of implantation exactly as the dogma says, on day progesterone plus 5, but others have the window displaced. They have the window the window open on day plus 4 or on day plus 6 or day progesterone plus 7. Now, we have done now more than 12,000 patients looking at the endometrial receptivity using the test, and basically, as you can see, in 70% of them, there is no problem. The endometrium shows receptivity. However, there is as much as 30% of our patients who show no receptivity, being most of them pre-receptive endometria. So we are transferring the embryos too early, and we have to delay in a subsequent embryo replacement the moment that we put the blastocysts into the uterus. Now, with this, we have published different papers, first the discoveries, then the comparisons with the noise criteria, the reproducibility of the test, and we have analyzed different conditions in different papers that probably many of you already know. What it was missing was a prospective randomized trial in which we analyzed the value of analyzing the endometrium and coming to the concept of personalized embryo replacement. So we want not only to analyze the endometrium, but also perform the embryo transfer exactly at the moment that the test tells us that the endometrium is receptive. With this in mind, we started a prospective randomized study in which the endometrial receptivity and therefore personalized embryo transfer was addressed in comparison to regular procedures, fresh embryo replacement of embryos or frozen replacement of the embryos. So in one arm of the study, we included the regular fresh embryo transfer. In the other one, the deferred or frozen embryo transfer. So this may compare to what Dr. Koutifaris was discussing with you. And in the third arm of the study, we add a previous analysis of the endometrial receptivity to transfer the embryos in the appropriate moment. The study was registered properly in the clinical trial identifier, and then the sample size was approximately 546 women, in whom these were the inclusion criteria. To note that PGS was not an inclusion a requisite. Some of the cycles were PGS, but was not an inclusion criteria. So basically, the study, therefore, was to replace blastocysts on day 5 or 6 of development, either in a fresh cycle right after ovarian stimulation, or to collect and make embryos in the lab, but freeze the embryos and replace them after freezing and thawing, or in a third group, they underwent a test of endometrial receptivity, and then the frozen embryos were replaced according to the results of the ERA test. And this was the estimated sample size, but we did an interim analysis that was presented in the last meeting of the American Society for Reproductive Medicine, and this analysis included more than 100 patients in each arm of the study. So this is basically the results of this study. Here you have again each of the 3 groups, the number of individuals included, the number of dropouts, the age of the patients, and the number of embryo replacements that had been performed in this interim analysis, basically 51%. And this is results, the preliminary results of the study. As you see here, the pregnancy rate per arm was 61% in the first group, approximately 61% in the second. However, in the personalized went up to 85%. The implantation rate was similar in all the groups. There were no differences in biochemical, ectopic, or clinical miscarriages, and the ongoing pregnancy rates, however, were not different, were a little bit higher in the personalized embryo transfer, but there was no difference in this interim analysis among the 3 groups studied. So basically, using this personalized way of embryo replacement, what we have done is to increase the chance of pregnancy basically by 14%. So we know today that analyzing the embryos, doing PGS, we can replace euploid embryos, and in the best scenario, we can get 66%. We can improve by 14% pregnancy rates looking at the endometrium and replacing the embryos in the right moment, but altogether makes 80%. So we are still missing 20% of our patients. I don't think that we will never arrive to 100%, but we will try. And what I'm going to show you is another way, the third way that I would like to discuss with you today of looking at the endometrium, which is a very interesting story that you will listen more and more in the future. And that refers to the microbiome, the presence of microorganisms, microbial cells into our body. It's interesting, it's a very interesting topic because you may or may not know that our body contains 10-fold more microbial cells than human cells. So we have 10-fold more microbiota than real human cells. And they might do something in the functioning of our body. And in fact, the microbiome has been called the second human genome. So in 2012, in the Nature magazine, it was published the human microbiome after the studies of different institutions. And one of the particular topics that was addressed was the microbiome in the genital tract of the woman. And as you can see here in this PCA analysis of the genes involved, which identified the different the microbiota present in the urogenital tract, is very specific. It's as specific as it can be found in the mouth or in the skin. So there are very specific microorganisms localized in the human urogenital tract. So we did a study that, if you want more details, it was published in the November or December issue of the American Journal of OBGYN last year, so just a few months ago. So you can go there for details, because I don't have time for many details, although I have more time than I expected, to be honest with you, because I see that I still have 13 minutes. But basically, we were able to retrieve endometrial fluid and also vaginal fluid from women undergoing IVF, and analyze the microbiota, compare it with the endometrial receptivity test, but this is I'm going to skip that, and especially look at the outcomes of IVF according to the microbiota. And what is interesting is to find out that most of the microbiota in endometrial fluid or in vaginal or in the vagina is dominated by the lactobacillus. This is well known. But it was very interesting to find out that the endometrium had a different flora as compared to the vagina. Some flora was totally only found in the endometrium as compared to the vagina. So it was not localized in the vagina, but in the endometrium. So basically, we divided these specimens in those dominated by the lactobacillus and those not dominated by the lactobacillus, and we compared the IVF outcomes. Again, this is preliminary studies looking at different things, so the numbers are not high, but here you have lactobacillus-dominated microbiota and not lactobacillus-dominated microbiota, and we looked at the different outcomes of IVF. Just to make the story shorter for you, maybe you should look at the end of the table, where you see that the pregnancy rate per transfer or the implantation was higher when the lactobacillus was the dominant microorganism within the endometrium. Just putting the data in other way, more graphic way, you see how this was the microbiota representative of the cases in which we had a live birth, dominated basically by the lactobacillus. This was for miscarriages, and that was for non-pregnant women. So the whole thing, again, this is the initial studies, but you can see how there is a different way of looking at the endometrium, and perhaps in the next future we learn about it, and we can come here to these meetings with some clinical recommendations for you. For today there is no clinical recommendation, but again, you see how things point in different directions, and not only morphology and even omics. So today, what are we doing with our patients who have a failure, repetitive implantation failure in ART? In these patients, we always do a morphologic assessment, and again, for us, ultrasound is of paramount importance. We do not use hysteroscopy for the reasons mentioned before. Only in cases that you find a pathological finding in ultrasound, then you have to do confirmatory and maybe surgical hysteroscopy. But if the ultrasound is okay, in my personal view, I don't recommend to do again a hysteroscopy. But simultaneously, we test the endometrial receptivity because we think it's important. And we have seen in this prospective randomized study, still with an interim analysis, the study is finished, but the data are not available yet. But we have seen that we can increase pregnancy rates at least 14%. So we check both. If there is a finding, obviously we have to use hysteroscopy to treat and to fix this problem. If there is a fibroid, if there is a polyp, we have to fix the problem. But if there is no morphological finding, we test the endometrium, as I told you, always, and we can find whether this is receptive or not receptive. If it is not receptive, we repeat it until we find that the endometrium is receptive. And that happens practically in all cases. We have only 1, 2 per 1,000 cases, 1 or 2 per 1,000, in which we were unable to find the window, the appropriate window of implantation. And again, once the endometrium has been found to be receptive, then we repeat an embryo transfer, but always with embryo selection. Embryo selection is another part of the story that I shouldn't cover today, but is absolutely important. So to finalize my presentation today, ladies and gentlemen, I think that the endometrium is important. It's not the answer to all the implantation failures, for sure, but looking at the endometrium, we are convinced that you can improve your outcomes. We still need to understand approximately 20% of the implantation failures, and again, as I show you, maybe microbiology is the answer of part of it. Maybe immunology has to be revisited. There are many studies, but still immunology has a lot to say, in my modest opinion. And finally, the study of the endometrium, as you can see, will include a series of things looking at the endometrium with a very wide scope, morphologically, functionally, and maybe other different disciplines that will come in the near future. Thank you very much for your attention.